Good afternoon, everyone. Welcome to our 10th webinar of the year. My name is Pauline Matindan Garcia. I am the Director of Care Transition for Livingston Memorial, VNA, and Hospice. I will be moderating today's presentation. Before I introduce our presenter, I'm just going to go over a few housekeeping notes. Today's presentation will be recorded and available for viewing on our website in a few days. This is also an interactive presentation, so if you have any questions during the presentation, please feel free to use the chat function on your Zoom app to submit your question. We will do our best to answer all the questions that you listed during the presentation. All the questions and answers will also be posted on our website along with the presentation. If you run into any technical issues, use the chat function as well to send us a message, and we'll do our best to help troubleshoot the issue you're having. So without further ado, I'm going to go ahead and present our very own and today's presenter, Dr. Lanyard Dial. Dr. Lanyard Dial is a leader in family medicine and geriatric medical education. He served as Director of Family Practice Residency at the Ventura County Medical
Hello,
Center.
Lanyard. This is Jerry Olson saying hello.
Hi, Jerry. How are you?
We'll see you in a couple of weeks in Kelly Methodist Church.
That's right. I actually have to give you a call, Mr. Jerry, in a little bit just to coordinate those details. So Dr. Dial has been a national leader in geriatric continuing medical education with the American Academy of Family Physician. He was the chairman of the Geriatric Review Course, developed and taught the geriatric section of the AAFP's Family Practice Board Exam Review Course. Dr. Dial has served on the Physicians Advisory Board of the Ventura County Alzheimer's Association. In 1986, he became the medical director of Livingston Memorial Visiting Nurse Association. In July 2007, Dr. Dial became Livingston's CEO and president and medical director. In June 2021, Dr. Dial retired from the CEO president position, but continues his passion as Livingston's medical director. As a longtime Ventura County resident, Dr. Dial works to improve the quality of medical services for the elderly, homebound, and terminally ill. Dr. Dial received his medical degree from Washington University School of Medicine in 1981. He is a diplomat with the American Board of Family Practice and holds certificates of added qualification in both geriatric medicine, hospice, and palliative medicine. His faculty appointment is a UCLA Associate Professor of Family Medicine. Without further ado, Dr. Lanyard Dial.
Thank you, Pauline. Thank you all for joining us. Today, over the next hour in the webinar, I have the opportunity to help you understand palliative care. Palliative care is a unique aspect of the clinical care that's available in the United States and available in Ventura County. And it's my honor to be able to help lead palliative care here at Livingston and to try to help you best understand that. As Pauline mentioned, I'm happy at any point to answer questions. Please put those into the chat, and I will certainly save some time at the end for questions and answers. Let me turn to my slides so that I can show you the information that keeps me on track for what I want to make sure you understand. So we're speaking today about palliative care. And one of the things that I want you to understand is that, from my perspective, palliative care came out of the concept that modern medicine after 1945 is the date I tend to pick, because post-World War II, we developed a lot of medical care that we still are using today and have advanced medical care since that time that includes antibiotics, vaccines, modern surgery. And so that really got us going in the field of medicine over the last 80 years. We understand a lot about various diagnoses. We understand treatment for the variety of human diseases that exist. There was no textbook that was given to us that said, here's everything that goes on in the human body and everything that can go wrong with it and how you treat it. We've had to learn those things, and medical education and a lot of what I do in continual medical education is providing information to current physicians about what's going on today in new ideas about diagnosis and treatment. But understand that now we have a very sophisticated medical system that can diagnose and treat many, many diseases. I'm going to restart this just to see if I can't get that glitch out of it. There we go. Let's share my screen. So as I was saying, we've developed a lot of preventive treatments and a lot of treatments for various diseases, varieties of medications, varieties of surgeries, varieties of vaccinations to help people stay as healthy as they can. But what that has done is created a lot of people who are still alive because we have provided them with outstanding medical care, but they still have the diseases that have affected them, and we're still treating them for those diseases. It's rare in medicine that we cure a particular disease and get rid of it. You might think of a 17-year-old who comes in with appendicitis, and we take them to the operating room, we remove the appendix, their scar heals up, and they go on about their life totally fine, having had a history of having appendicitis, but cured of that illness. Or a broken bone that we can set and fix, and it heals up totally, and they are cured of that broken bone. But the vast majority of diseases that we have, people get treatment for, but they live with. On this list, chronic lung disease in the upper left-hand corner comes to the top because it's one of the most common illnesses that we see. People with bad lungs over their lifespan, and we attempt to treat those. We have medicines, we have surgeries. Heart failure and vascular diseases, the #1 killer still in the United States, people dying of heart disease. But we've done some amazing things. We're now able to fix valves without going through someone's chest. We can put an artificial valve in through a cannula that we push up into the patient's femoral artery. We can fix and take care of hypertension throughout one's life. We've got excellent diseases to unblock coronary arteries or prevent them from fully blocking up. And so we can keep people away from having heart attacks. We've got excellent treatment for chronic kidney disease on the right-hand side with both peritoneal and usual transfusional dialysis. We've got kidney transplants we can do. Many of the cancers, which historically killed people pretty rapidly, we have been able to diagnose some even early enough that we can get them totally out and believe that In a lot of those cases, we actually have eliminated that cancer from the person's body. Even if we haven't, we've got excellent treatments to keep that cancer at bay. We've got excellent prevention to try to prevent cancers from developing. So all of these on this slide are ways of thinking about medicine's effect on our society. That even though we haven't been able to cure and get rid of them, we are able to treat them and keep people alive longer with the illnesses that exist here and that they still have. That's altered the way in which people in the United States die. Historically, people died with a big heart attack. People died with a terrible pneumonia. People died because their kidneys gave out. People died because we hadn't discovered insulin and we didn't have a treatment for their diabetes. So acute deaths were the history of our medical care. But now, again, since World War II, and I would say for sure in the last 15 to 20 years, people are not dying acute deaths as often. We're able to do something to help them, but we keep them alive longer with their diseases that we're treating. And so their deaths happen because that illness progresses and we're no longer able to treat it. Or they get a secondary illness. You're aware, I'm sure, of treatments for cancer causing cancers later in people. Or treatment for cancers with various chemotherapies failing and that cancer becoming resistant and causing death. So we've shifted how people die in America from acute death to a more chronic death is coming and we understand that it's coming, and we're doing our best to provide the medical care to keep those organs working or that cancer at bay. So whatever chronic disease an individual has, be it heart failure or lung disease or diabetes, renal failure, cirrhosis, you can put the whole list up there that are serious bad diseases. And this is at any age. Children with cancers, children with cirrhosis of the liver, children whose kidneys are giving out. They have diseases that we are keeping them alive longer because of our treatments. But all of those illnesses progress. All of our treatments start to create problems or not work. And there's a gradual decline in that person's ability to function, where they progressively lose their ability to be more independent and they rely more on caregivers and support to help them until that illness becomes terminal and people die. Hospice developed in the 1960s till about 1986 in our communities out of a group of volunteers recognized that terminal phase needed to be managed and helped and treated so that people died comfortably. And in 1986, a medical model was developed in our community, was brought into law by Medicare, and has existed as it is since 1986, and is followed, that medical model, across the United States by all the hospice agencies that exist. The payment for those comes from Medicare, but it also comes from every insurance that's available and out there, so that your Blue Cross, your Blue Shield, your Kaiser, they all follow, though, the medical model that Medicare and the medical community developed in 1986. And that's really important to understand. We developed a model by which people who are dying could get care in their home, where they're living, so they could die peacefully. That's what hospice was. It's a model of care for patients who have terminal diseases, who seek comfort care because their ongoing medical care is no longer capable of curing them, and coming into hospice allows them a comfortable and peaceful death. The medical model of hospice that was developed centered around the patient and the family, but with a team. That team has been called a multidisciplinary team. It's also been called an interdisciplinary team. That team includes a medical director, a physician who is a leader in the field of hospice care, who understands the drugs and the treatments for hospice care. For Livingston, that's been me. We created this, brought this model into Livingston in 1986. We also involve other physicians and physicians in the community, nurse practitioners. The central second key leader in this is a nurse. A nurse who's trained in hospice and palliative care, who works with the patient and family and me to make sure that person gets the care they need. There are CNAs who help us with bathing and personal care. We have grief specialists, we have chaplains, we have volunteers, we have social workers, and all of that team is part of the model that Medicare wrote into law in 1986. That model of hospice care goes on across the United States today. Now, what about palliative care? What's different here? Well, it was developed in 1990, and it was developed out of the recognition that hospice care was not available for people who were not terminally ill. Hospice and that model required a patient to be terminally ill. Palliative care, therefore, was not available to patients who were not terminally ill. Between 1990 and about 2000, there were a lot of push and development that defined what people believed palliative care should be and promoted using the hospice interdisciplinary team model for patients who were not terminal. And so what began during that time and still exists today in modern palliative care is the idea that there's an interdisciplinary team model of people providing care to non-terminal patients. So in this diagram, which you saw once before, with the chronic diseases, that gradual decline of function into a terminal phase that leads to death, hospice is appropriate and used in that last part of that. Palliative care sits here. Palliative care is available to people who are not terminally ill, who are seeing a progressive and gradual decline in their abilities. And it's an interdisciplinary team model brought in to help those patients. So let's go back up to the chronic disease. A patient now with liver cirrhosis or heart failure who is doing fine and getting treatment probably is not someone who would fit in to a palliative care model. But as they're getting worse and that illness is progressing, they can move into the palliative care model. You know, there's an old, as best as I can tell, it came out of the 15th century folk saying about physician care. It's been attributed somewhat to Hippocrates, but most people think it came earlier than that. To cure sometimes, to relieve often, and to comfort always. And that, I think, summarizes a bit why palliative care came into being. We recognize we can cure people, but many of the illnesses that we now face, we can only relieve those symptoms, but we ought to be able to provide a level of comfort for everyone, not just people as they get terminally ill. Palliative care, by the word, has been around longer than modern palliative care, obviously. Palliative care as a word came back in the Middle Ages. It was to make a disease or its symptoms less severe or less unpleasant, even if you can't have a remedy for its cause. So, traditional medical care, care for your illnesses, care for you to get your vaccinations, care for you to get your treatment for your lungs or your heart or your kidney disease, care for a childhood cancer, aggressive traditional medical care, doing everything modern medicine can do. But at some point, as that illness or the illnesses that accumulate in an individual, or that illness gets worse, you can add a palliative care model to help support that patient, to make sure that we're providing relief of symptoms, to make sure that we're able to help them through the processes that are going on. And then when appropriate, and that person becomes terminally ill, they shift into the hospice care medical model. So I hope what you've seen so far is the location at which palliative care sits in the medical world. Let's talk a little more specifically about it. So obviously it's care that's focused on the relief of pain or anxiety or other symptoms that come in when people have diseases. It's care that helps coordinate services for families and for patients. It's involved not just with treating the disease, but focusing on the symptoms of that illness and the things that happen to a person because of that disease. The patient who is appropriate for palliative care is not terminally ill. The care is designed to be supportive of the curative treatment that the patient is seeking. So the patients continue to get dialysis, they continue to get cancer treatments, they continue on heart transplant lists. So the patient does not come out of their traditional medical care. Palliative care is superimposed and added on top of that traditional medical care. And the goal of relieving symptoms and suffering, providing the best possible quality of life for the patient and their family. Sometimes you'll hear both of these referred to as comfort care. I've seen doctors say the patient's on comfort care, and in that regard, they mean one or the other of these. These two terms, palliative care and hospice, have been confused, have been aligned as being the same thing. They are very different, and I'm hoping so far you're appreciating the nuanced difference between these two. Hospice, designed for terminally ill patients, palliative care designed for patients with serious illnesses, but are not terminally ill patients. In that way, if you think about it, everything that goes on in hospice is palliative care. It's all about the team. It's all about providing comfort. The difference is hospice is a smaller group population that's terminally ill, whereas palliative care is for people beyond that, people who are not yet terminally ill. Palliative care, another way of looking at it, can receive it at any stage in the disease, and it goes along at the same time as curative treatment. Whereas hospice care at the bottom is for terminally ill people with a prognosis of 6 months or less, and obviously it can extend out. Most of these patients are not getting curative treatments because those treatments are no longer being effective. Where they overlap is they really focus on helping the patient and family optimize comfort, reduce anxiety and stress, providing emotional support, relieving symptoms. Both models look at that as their priority. So hospice, end-of-life care, 6 months life expectancy, the Medicare guidelines that were developed in 1986 that have been part of our medical model since that time, looking at interdisciplinary teams. There is reimbursement by Medicare and insurers to cover every expense that's involved in hospice. In hospice care, curative therapies are not part of hospice care because the patient is beyond that. The patient doesn't require or need ongoing chemotherapy or radiation therapy or blood transfusions or IVs for fluids. They're no longer having curative treatment going on. Hospice care, as you're aware, is usually provided in patients' homes. It can be wherever they live, in a residential care facility for the elderly, the RCFE, or in a skilled nursing facility. So hospice has that structure, and contrast that to what I've been telling you, and I want to point out some specifics in palliative care. So it's for a chronic condition, conditions that are usually life-threatening. They're usually not good conditions. For example, if you broke your bone and you had a long-term infection that needed to heal, that wouldn't be appropriate. You're going into palliative care. Palliative care isn't there for every treatment of every disease. It's there for conditions as they're getting worse, as the patient is having more problems and more illnesses. There are no written Medicare guidelines for palliative care. And as such, there is no Medicare reimbursement for palliative care. So palliative care has not gained the favor of Medicare so that it can structure it. Medicare has yet to tackle the realm of palliative care, which is one of the big issues. As I mentioned, it was developed in the 1990s through 2000. And unfortunately, because it's an add-on to your traditional care, Medicare doesn't recognize that add-on as something they're going to reimburse people for. Now, they have developed a reimbursement process for the doctor. So they will pay a physician as a consultant for palliative care, but they don't pay for the team. They don't have a system yet, and the yet is really important to understand, because I believe that they're working hard to work this out, where a team of people are reimbursed to provide palliative care. Hospice, the team of people are reimbursed to provide hospice care. But palliative care, as of yet, there are no guidelines and no reimbursement, which makes it a little bit of a problem in that there is no national standard for exactly what goes on in palliative care. And since there is no reimbursement, everyone who's doing palliative care has to figure out how do they financially support those kind of programs. In the realm of palliative care, as I mentioned, to differentiate it from hospice, it's added on, and it's an option that curative and palliative care go together. Because of the no reimbursement, the major location where palliative care has been taken on aggressively has been in hospitals. They have developed palliative care services. They have developed palliative care beds. Hospitals have felt that providing a team of professionals where they pay for that team of professionals to oversee and help people who are getting curative treatments also get palliative care support, they have felt that that has been a benefit to the patients in their hospital. So in the United States today, the vast majority of hospice-based teams exist within our hospitals. There are community-based palliative care teams, and they tend to be part of hospice or home health care. And as part of hospice or home health care, the reimbursement for them is taken from either the hospice side of the program or the home health care side of the program. So the community-based palliative care doesn't have the backing like community-based hospice does. It doesn't have Medicare or other payers willing to pay for it. Now, there are a few insurance companies well ahead of the Medicare system that have said, we recognize the benefit of palliative care, and we're going to pay for a team of professionals to provide palliative care for our insurance beneficiaries. Some of those are the large conglomerated medical service care providers. The biggest example in our area is Kaiser. Geisinger in the Midwest, Providence in the Northwest. Those systems have designed community-based palliative care as part of their team and providing that in those communities. After 2000, this is a graph showing you palliative care programs within U.S. hospitals. And what you can see is as of 2020, close to 85% of U.S. hospitals had a palliative care team and program inside the hospital. It's been a tremendous benefit to patients, a tremendous benefit to the communities. It's really brought about the understanding and importance of palliative care to our country, but hospitals have been the site and main source of palliative care through the years. I think you've got this, the traditional medical care, adding palliative in and moving into hospice care. Another way of looking at it, I've seen this graph out. People are getting curative therapy for their illnesses, and somewhere along the way, palliative care is added in, and then they move into hospice care. What does palliative care's team actually do? And I've mentioned some things already, but I want to be even more explicit about them. The team in most palliative care hospital services or in most community-based services has the patient and family as their key focus, have a physician who's responsible for the medical oversight of that system, has a specialty nurse, has a social worker, and has a chaplain. Those are the major structural points of palliative care. Now, if you compare that diagram to what's in hospice, you see it's missing a few things. It's missing volunteers. It's missing nursing aides. It's missing someone who will do personal care. So the palliative care team is a stripped down team from the hospice team. Its goals are to provide the palliative care services necessary to that patient and their family. What kind of services and what did they do? Certainly, one of the most important things they try to do is work so that the patient and family understand their illnesses, understand their treatment plans. Remember, these patients and their families are seeing and are involved with ongoing traditional medical care doctors. So an oncologist, a pulmonologist, a family doctor is that patient's doctor and works with that family. Palliative care comes in to add to that. And what can they add? They can look and help the patient and family be sure they understand the diagnosis that's happening, be sure they understand the treatment plan that's happening, spend time to answer questions about those diagnoses and treatment plans. In the traditional modern medicine way of dealing, hospitals are now providing patients with doctors in the hospital called hospitalists. Those individuals tend to be very busy people managing the acute medical care of that person. The palliative team can help add to that hospitalist care by spending more time with the patient and the family, answering questions about the diagnosis and treatment plan. So that's a primary focus of a palliative care team, particularly in a hospital, but also in the community, because many patients in the community are seeing 2 or 3 different doctors and trying to help put together what is actually going on, what diagnoses and what treatments are being offered or is the patient using to help them as they're managing these chronic diseases. One of the lingos that's very common in the world of palliative care I want you to hear, and it's called goals of care. You'll hear the idea of a goals of care discussion, a palliative care team focusing on the patient's goals of care. What this means is trying to identify from the patient and their family what they understand about the future of their diseases, what they want in the future related to the treatment and management of those diseases, how to best utilize the medical system to meet those goals that that person would have. So a common lingo in the palliative care world is helping review with the patient and family their goals of the medical care they're getting. As an example, doctors may be very much aware as they're trying to provide care to this individual that it's highly likely this person will need more support in their living environment. That support can come from them being at home, hiring people, or from them going to live in a residential care or a skilled nursing facility. Talking through how the patient and the family would like to see those functional needs met, those living arrangements organized, is a clear role of the palliative team helping review the patient's goals of care. They also have very frank and realistic discussions about prognosis. What does it mean when the doctor has said that this chemotherapy is for palliation only? How does that, what is going to happen as that therapy is given? And what can the patient and family expect? So a palliative care team does a wonderful job of sitting with the patient and family, helping clarify the treatment plan, presenting realistic prognoses, and trying to align the patient's goals with the medical team's treatment options. And then what lots of people think palliative care does is really one of the last things on the list is advise on particular symptoms, how to better control the person's pain, how to better control the person's nausea. So symptom management is certainly a part of what palliative care does. It's a very interesting and awkward position of a palliative physician because that palliative doctor is not the patient's primary doctor. The patient's primary physician is their family doctor or their orthopedist or their oncologist or their pulmonologist, and the palliative physician and the palliative team therefore give advice on how to better manage that symptom for the doctor and the patient to discuss. What was very interesting early on, and this article was published in 2010, was the obvious benefit that palliative care gave to people. And I think this information shocked a little bit of our country, that patients with metastatic lung cancer who got palliative care team involvement early in that disease and that treatment, and the patients were still getting their standard care from their oncologist, and you compared that group to individuals who didn't get any palliative care, just got the same oncology care. Throughout the remainder of that person's life, they showed less episodes of depression. They felt their quality of life was significantly improved, and they actually survived 3 months longer if they had palliative care earlier in their disease. This hit the New England Journal, one of the most prominent journals in the United States, and really established that palliative care has a significant role to play, added on to other types of services that patients are getting. What should you expect as an outcome from palliative care? What should you expect happens? You should certainly expect that if palliative care gets involved with you or your loved one in a hospital or in a community program, that the understanding of your diagnosis, your prognosis is clarified better than if palliative care hadn't been there. Create a plan designed to meet your goals of care and look at your symptoms and see if we can help meet symptom management so that you have a better quality of life. What symptoms? Well, the obvious first two are common across the board. People worry about pain and they worry about anxiety and fear. And those two go hand in hand. If you're anxious or fearful, your pain's going to be worse. Pain creates anxiety and fear. So the management of those two symptoms are two of the key symptoms in patients who need good palliative care and, for that matter, good hospice care. Being short of breath, and the medical word is dyspnea, is a focus of the palliative care team. There's nothing worse for an individual than if they feel they're always short of breath. Suffering. Now that's a tricky word because it doesn't have a clear medical diagnosis. I've seen and heard people who have significant suffering, and the treatment is to have a chaplain meet with them and work through how they are reacting, what they're worried about between them and their spiritual feelings. So suffering is an important component of us as humans, and palliative care tries to address how can we help you so that you suffer less, which is why every palliative care program has as a member of its team a chaplain-based service, has as a member of its team a social worker who can help with anxiety, fear, suffering. So those are important symptoms we manage. There's also a whole other list. I just pulled some of them. Nausea, constipation, itching, hiccups, incontinence, skin breakdown, things that go on with chronic illnesses that are bothersome, and palliative physicians, hospice physicians are well attuned to how best to treat this kind of group of symptoms. There are two key issues that I've touched on that I want to clarify and be sure you understand. Palliative care in the United States suffers from a lack of recognition by Medicare. Medicare nor most private insurance payers recognize the importance of a palliative care team model. They might pay for a physician to do one consult. They might pay for a follow-up consult. The teams are organized and paid for in a different way. And the teams, as you've heard, I hope, from me already, are essential to providing good palliative care. A single individual consultant of a physician can only do so much. Having a well-trained nurse, a social worker, and a chaplain as a part of that team is a really huge value for patients with chronic diseases to help them through what they see as their future needs. Second big issue, the palliative care team is consultative to the primary doctor. The palliative care team does not take over the care from the primary doctor. So any recommendations for treatment are not in the purview of the palliative care physician or team to enact. It's in the purview of that person's physician who's managing that case. So there's an obvious conflict between the doctor who's managing your care and the palliative team trying to balance how to help you through this. And that exists throughout all the palliative services in hospitals or in the community. As a great example of that for you to understand is that the care you get in the hospital or on an outpatient basis isn't coordinated because the teams are not continuous teams. There is no inpatient palliative care team that runs an outpatient palliative care service where they're going to prescribe medicines. That has been tried, that has happened, but it's not effective because there's no funding to continue to make it work. So most of the teams who are based in hospitals will see the patient, make recommendations, but there is no outpatient effective arm. If the patient enters outpatient palliative care, that is to manage what's going on in their community. They're working with the doctors in the community separate from what was developed by the inpatient palliative care team. So that continuity is a huge problem. And then one thing that most people don't understand, but is significant in the United States, particularly in the last 5 years, hospice doctors have exemptions for prescribing. As a hospice physician, I am allowed to go around prescribing law in the United States, meaning prescribing law in the United States right now says all narcotic prescriptions must be computerized and patients can only get 30 days worth of pills, and they must be seen every 30 days by the prescribing physician, and that prescribing physician must have a contract with a patient who's taking ongoing narcotic medicine. Hospice doctors are exempt from those prescribing rules. I can prescribe what the patient needs, and I can do it over the phone, and I can change it immediately. So that my ability to prescribe narcotics or benzodiazepines, medicines to relieve anxiety for hospice patients are completely exempt from a lot of the FDA laws. That is not true for palliative care patients. That is not true for palliative physicians prescribing. So one of the significant problems is getting people the medicines they need to manage their symptoms in the current existing palliative care structure. In the hospital, the palliative care physicians rarely write those prescription orders. They turn them over because they're consultative to the primary doctor. And when the patient goes home, they rarely prescribe them because they have to follow the current laws and rules in the United States, and those require visits and documentation far beyond what is required for hospice physicians. So those are significant issues. Palliative care is a very complex system. I hope you appreciate that. I hope you appreciate how it fits in the model and structure of medical care that goes on today. I hope I've told you how it came to be and where it sits in the current process of needs of patients, and I've tried to share some of its current issues. Keep your eye open on this one because I believe this will alter and change over the next several years. We've had the 20+ year experiment with how this might work. We have been incredibly successful at developing palliative care in the hospitals. We certainly have proven, I believe, that palliative care helps people. And I think there are major insurance carriers who believe deeply that this is a benefit and who have picked this up and developed this for their patients. But for the general population, the lead group in the country, Medicare, still does not have this as a major program for them. As I mentioned, I think that will be coming, and Medicare is working on it. I will stop there and answer any of your questions.
Dr. Dial, we received a few questions. The first one is, what distinguishes palliative care from regular home health care? Can my loved one have both at the same time?
So home health care should be thought of as traditional medical care. Palliative care can be added on to home health care, just like it's added on in the hospital to your traditional medical care. So palliative care as part of home health care services exists at Livingston for sure, and at many of the other home health care agencies. The logic is there's a palliative care doctor, myself for Livingston patients, There's a palliative care nurse, a chaplain, and a social worker who, as a team, interact with that patient and work to ensure that their traditional medical care continues and that they're supported with the palliative services. But the same issues and problems I pointed out exist. There is no good structured payment. So within Livingston, if you're a Livingston home health patient, we don't get additional dollars because palliative care is part of your process. We don't have a mechanism to bill an individual service. Now, Kaiser patients will reimburse us for providing palliative care because that's what Kaiser does. But that's not the majority of the patients we're taking care of. Home health care, adding on palliative services, you must fit into home health care while we add the palliative services, because then we can be reimbursed for the home health care and we internally then shuffle the money to offset the palliative services.
The next question is, what steps do I need to take to begin palliative care for my family member?
As I mentioned, I think the best option is in the hospital, because that is where in Ventura County, the majority of palliative care teams live. And so anybody who has entered the hospital for your loved one is in the hospital, you can request from the physician, you can talk to the nurse at the hospital who's taking care of your loved one, that you would like to see if they could add palliative care help for your loved one who's there. If your loved one is in home health at Livingston and you believe that palliative care might help them, you can certainly talk to your home health care staff and we can query your physician to see if they feel comfortable adding palliative care services for you. We have those available, we can add those in.
How do I know when it's time to transition from palliative care to hospice care?
That's an excellent question. Palliative care, as you saw in my slide, is that middle. It's that middle where the chronic disease and diseases and their treatment is starting to not work as well, and the diseases are starting to add in, and the person with these illnesses is starting to lose ability and function. Hospice is appropriate when it's believed that that person is terminally ill and ready to enter into an idea and a model that supports them through their terminal process. So when do you transition from I'm in the midst of treatment and chronically getting services, having palliative care help me, and then move to becoming terminal? There are a few aspects of that I would say should tip you off. One common one that we talk about a lot with our staff is, would anyone be surprised if this person died in the next 6 months? Would that surprise somebody? And if it's in your honest opinion, you go, no, I think they're pretty sick, then they're hospice appropriate. I think that's a pretty easy way of thinking about it. Certainly losing function, we have all kinds of functional predictive models. When people's chronic diseases have gotten so bad that they can't get out of bed because they're so weak, they're appropriate for hospice. But they can be appropriate for hospice much earlier than that. We have patients who have had significant cancers, their chemotherapy is not working, but they're still capable of driving and being up and around and cooking. But it's clear that without the ability of chemotherapy to stop their cancer, they're terminally ill and they are appropriate for hospice care. The appropriateness for hospice care to enter into the program requires two main steps. One, your doctor must give an order that says, I believe this person is appropriate for hospice care. Step 2, I, the medical director, have to agree with that doctor. How do I do that? I base it on records that doctor has created. I base it upon an examination by our staff who've come and seen that patient with their family, and they contact me and explain what they're seeing and what they believe. And sometimes I actually see the patient or call the doctor directly and have my own way of looking and going, this person is totally appropriate for hospice care. So Medicare requires your primary doctor to have and all insurances. Part of the model's design, primary doctor must say you're terminally ill, and I must agree with that.
The last question I have is, can I ask my primary doctor if my loved one can be evaluated for palliative care?
Absolutely. And that would be usually for home-based, community-based palliative care. And in fact, if you ask us and our staff to enroll you into palliative care if you're in home health care, we will call your doctor and say, your patient's family has asked if we could bring them into palliative care and add palliative care services for them. Would that be acceptable to you? Because the physician who's taking care of you has to order your home health care and has to order your palliative care.
That's all the questions I received through our chat. If anyone else have any question, please feel free to unmute. You can ask your question directly to Dr. Dial. Going once, going twice.
Okay, thank you all for attending today. We will have, this is recorded, so it'll be available to you.
Thank you all. Have a great afternoon.
Bye.
Bye.
Appreciate it very much.